Good morning, everyone. I'm Dr. Alaa Mosbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. Today, I wanted to discuss with you gynecological examination, or what's called pelvic examination. So, we want to discuss the general approach, general examination, preparation, abdominal examination, preparation to pelvic examination, external genital examination, speculum examination, bimanual examination, rectovaginal examination, BR examination, completing the pelvic examination. Okay, let us start with the general approach. Wash your hand first. Introduce yourself to the patient. Tell her about your name and your position. Confirm the patient details as regards the name and the date of birth. Explain to the patient what the examination involves and why it is necessary. Obtain verbal consent. Then start by general examination. General well-being first. See if the patient at ease or distressed by physical pain. What is the gait? Is it limping or normal? Constitution, is it feminine or masculine? As you see in the picture here, this is masculine constitution when the shoulder is bigger than the waist. While the feminine one, the waist is bigger than the shoulder. The belt, measure the body mass index, which is normally 18, body mass index, which is normally 18.5 to 24.9 kilogram per square meter. Head and neck examination, conjunctival pallor, jaundice in the sclera, lips for cyanosis and pallor, and the undersurface of the tongue also for cyanosis, thyroid for any nodules or enlargement in goiter or any nodular thyroid disease or tumor, lymph node enlargement in the neck, and edema in the face and the neck. As you see in the picture, this is cyanosis in the lips. Measure the temperature also and respiratory rate as a part of the vital signs. Palpate the radial pulse and measure the blood pressure. Do capillary refill test. Less than 2 seconds in normal, but it is prolonged in hypovolemia. So you can do the test as seen in the picture by pressing on the nail bed for 5 seconds, then release, then see when refilling will occur. If within 2 seconds it's normal, if more than 2 seconds there is delayed refill, means there is hypovolemia. Search in the nail also for nail cluttering, which occur with heart problem and chest disease. Examine the breast, chest, heart, limbs, and the back for any abnormalities. Leg and the feet for calf swelling, ankle edema, and varicose vein or deep venous thrombosis. Preparation to abdominal examination. Patient should have an empty bladder. Expose the abdomen from xiphisternum to pubic symphysis, as you see in the picture. This is the exposed from xiphisternum here to symphysis pubis here. Ask the patient to lie in supine position with the head of the bed raised to 15 degrees. Prepare any needed equipment like measuring tape. Inspect the abdomen for what? Note the shape of the abdomen and the movement with respiration and any visible mass. Inspect the umbilicus for hernia or for infection or discharge and its position also. Inspect the hernial orifices and the pubic hair, and is it feminine or not? Feminine hair, of course, triangle with space up, while in masculine pubic hair or male-like pubic hair reaching the umbilicus, triangle with apex up, not the base. Skin pigmentation or dilated veins. Search for any scars in the abdomen, like cesarean scar, and as in this picture, previous cesarean scar, previous midline incision here for laparotomy. And when you see the scar, you should describe the scar as regards the site, the size, the shape, the healing, primary intention or secondary intention, is it atrophic or hypertrophic or keloid scar. It is very important to describe the details about the scar. Ask the patient to comment on any tenderness during palpation. Observe her facial and verbal response throughout. Note any guarding. Palpate the 9 region of the abdomen as seen in the picture here, starting from the lower right iliac region here and extend, as you see in the other picture here also. So examine the 9 region in the abdomen. First, superficial palpation for tenderness and rigidity and for feeling any superficial masses, and to find if there is guarding or rebound or tenderness. Then deep palpation for organs like liver, spleen, renal angle for kidney, or other abdominal mass. And when you find any mass in the abdomen, like ovarian mass, uterine mass, you should describe the site, the size, the shape, the consistency, the mobility of the mass from side to side and the up and down. Is it fixed or limited mobility or freely mobile, up and down and from side to side? Of course, we know that the ovarian mass, when reach the abdomen, usually it is mobile from side to side and up and down. While uterine mass can be mobile from side to side, but not up and down because it is pelvic abdominal mass. Percussion and auscultation for shifting dullness in case of ascites, and we see sometimes with ovarian tumor, especially the malignant one, ascites, also in mixed syndrome, which is ovarian fibroma associated with ascites and right side hydroceles. So do shifting dullness for ascites as you see in the picture. This is the percussion, how to do it, and do auscultation to the abdomen like this picture to hear the intestinal sound and the venous hum. Then go forward for preparation to pelvic examination. Explain why the examination is being done and describe the steps in the examination. Ask the woman to empty her bladder and wash and rinse her abdominal and genital area for examination. Check that instruments and supplies are available like this. This is casco speculum, and all instruments needed should be ready. This is the examination table also ready. Ask the woman to undress and help her onto the examination table. Like this one, the patient is sitting, lying on the examination table. Wash hands thoroughly with soap and water and dry them with a clean, dry cloth or allow them to air dry. Ask the woman to lie down on examination table. This picture to show you different position for examination. This is the supine position. This is the prone position. This is the dorsal recumbent position. This is the lithotomy position. This is squatting position. This is standing position. This is knee chest position. This is sitting position. This is Sims position. In case of fistula, we use Sims position. Okay, so we choose the best position to do examination needed. Usually we use the dorsal position, okay, and sometimes the lithotomy position. For any other purposes, we can use other position as seen in the picture. Okay, let us start with the first local examination, which is external genital examination. Position woman and move drap over woman. Wash hands thoroughly and dry them. Put high-level disinfected surgical gloves on both hands. Respect external labia, clitoris, and perineum. This is the clitoris. This is the glands of the clitoris, and this is the prepuce of the clitoris. Okay, this is labia majora. This is labia minora. This is the fourchette, and this is the perineum, and this is the external anal sphincter, and this is the mons veneris. And inspect all this external genitalia for any lesion or ulcer or inflammation or scratch marks or inflammation. Perineum for any injury, tear, or short perineum. External anal sphincter for absence of corrugation around the sphincter, means weakness of the sphincter. Any previous perineal tear, third degree or fourth degree, should be mentioned if present. Okay, as you see in this picture, this is porcelain cyst. Normally it is not visible, but if in case of inflammation or obstruction of the duct, we can see the porcelain cyst in this area in the external genitalia, and sometimes porcelain abscess, making S shape to the vaginal introitus. S shape due to swelling of one or porcelain gland, making porcelain cyst or abscess. Okay, this is another mass protruding through the vulva. This is genital prolapse. This is cystocele, and this is the cervix, cervical descent or second degree uterine descent, extending outside the introitus. This is the center of the vaginal wall with the wall of the bladder, anterior vaginal wall with the wall of the bladder. It's called the cystocele, and this is second degree uterine descent, okay, in genital prolapse. So, check labia minora, clitoris, urethral opening, and vaginal opening. Check skin gland and urethra and take measure if discharge is present. You should take a smear. This is the external urethral meatus and the skin's glands beside. If any discharge, take smear from it. If any discharge coming from porcelain cyst, take smear also. Ask the woman to bear down while holding the labia open. You can check for any bulging mass, as in cystorectocele, as here in this picture, cystocele and uterine descent, after bearing down, will protrude through the introitus. If rectocele present, the posterior vaginal wall and the rectal wall will descend also. It is called rectocele. Also, in case of stress incontinence, when you ask the patient to cough or strain, spurt of urine will come out of the external urethral meatus, and this is called positive test for stress incontinence. Of course, you should do a separation of the labia to see the external urethral meatus and the vaginal introitus, and to see also any discharge coming through the introitus or bleeding. And lastly, you should look to the perineum, as we said before, for short perineum, for any injury, for previous tear, or any lesion. Speculum examination, as you see in the picture, this is the speculum examination, and this is the speculum, cusp speculum, and this is the model. This is how to hold the speculum between index and middle finger. The speculum contains two blades, handle and screw. Two blades, handle and screw to fix the speculum in place. Insert the speculum edgewise in the direction of the vagina fully and open the blades. First start longitudinal and in the direction of the vagina, downward, forward, till the half of the vagina, then rotate 90 degrees, then complete the insertion in transverse direction, then open the blade. This is so not to cause discomfort to the patient. Look at the vaginal wall and note any inflammation, ulcer or sores. Check for any discharge. Look at the cervix and the external os and note the color, position, smoothness or discharge. If the cervix bleeds easily or there is mucopus, obtain specimen for test. Remove the speculum in the reverse direction. Close the blade first, then withdraw till half of the blade is out, then rotate 90 degrees to get it out in longitudinal position, so not to cause discomfort to the patient. Then place this speculum in 0.5 chlorine solution for decontamination. I want to let you see some cervical lesions, some examples. This is for CIN. This is a CIN1, as you see, the aceto white areas here. This is CIN2. This is CIN3. This is cervical intraepithelial neoplasia, which is precancerous, can be changed to be cervical carcinoma in later life. So it's something important to diagnose this case early. Another cervical lesion, which is small polyp here. Here there is a large cervical polyp and a small cervical polyp. Another picture, let you see the chronic cervicitis with discharge, hypertrophy of the cervix, ectopy, and the ectropion. All these are signs of chronic cervicitis. So, chronic cervicitis signs, CIN, cervical polyp. Let us go to the next step, which is bimanual examination. As you see in the picture, two fingers, the index and the middle finger inside the vagina. This is the pelvic hand and the abdominal hand on the lower part of the abdomen, trying to feel the uterus and the adnexus. First, separate the labia with two fingers of the abdominal hand and insert the tips of the index and the middle finger of the pelvic hand into the vagina. Gradually insert fingers fully or until cervix is touched. Then palpate the uterus and check for the size, shape, location, consistency, mobility, and the tenderness of the uterus. Then locate the ovary and determine the size and the consistency and if there is ovarian mass or not. Check the size, shape, consistency, mobility, and the tenderness of any mass in adnexal. So, how to differentiate uterine mass from adnexal mass? As you see in the picture here, this is an example for uterine mass, which is uterine fibroid, intramural, subserous, pedunculated, subserous, intracavitary fibroid, submucous fibroid. So, this is uterine mass. Another picture for ovarian mass, an example for ovarian mass. So, this is for adnexal mass and this is for uterine mass. How to differentiate, we will see in this table. As regards the position, uterine mass usually central, while the adnexal mass usually lateral. As regards movement of the mass, transmitted to the cervix or not, the uterine mass, its movement transmitted to the cervix, yes. But in adnexal mass, movement not transmitted to the cervix, because the adnexal mass is separated from the uterus. Is there any sulcus between the mass and the uterus? There is no sulcus in case of uterine mass, but in case of adnexal mass, there is sulcus. This is adnexal mass, ovarian mass. There is sulcus between the mass and the uterus. As regards to consistency, mostly uterine mass is solid one, while adnexal mass may be cystic or solid. Okay, but more commonly to be cystic. What about the next step, which is rectovaginal examination? As you see in the picture, the middle finger in the rectum and the index finger in the vagina. If changing gloves, immerse both hands in 0.5 chlorine solution. Then remove them by turning them inside out. Then wear another sterile glove. Slowly insert middle finger into the rectum and the index finger into the vagina. Check for tenderness, as in cases with endometriosis in the rectovaginal septum, or masses between the uterus and the rectum as in enterocele. Immerse both gloved hands after examination in 0.5 chlorine solution. Remove gloves by turning them inside out and dispose of them in leak-proof container. What about BR examination? What is the indication of BR examination? This is a case with BR examination, as you see, using the index finger. The indications include diagnosis of parametrial infiltration in cancer cervix, detection of mass in Douglas pouch, diagnosis of rectal infiltration in gynecologic malignancy, differentiation between true and the false rectocele, diagnosis of rectovaginal fistula, also pelvic examination inversion. BR is used to substitute the PV because of afraid from injury to hymen, so we do BR in spite of BV or instead of BV. So use BR to do bimanual examination for evaluation of the uterus and the adnexia or any pelvic mass. Also, BR examination in case of pelvic endometriosis can feel the nodularity in the uterosacral ligaments and the tenderness in the uterosacral ligaments through BR examination. Completing pelvic examination, wash your hands thoroughly and dry them. Help the woman to sit up on the examining table and ask her to get dressed. Discuss any abnormal findings and what, if anything, she needs to do. If the examination was normal, tell her that everything is normal and healthy, and thank her. This is the end of my lecture. Thank you. I'm Dr. Alaa Mosbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University.